Okay. Now you should be seeing my screen.
Yes.
Okay, perfect. And you can see the first slide there, and I think you should all be able to hear me there. So thanks so much for joining today. This topic was identified as high importance in your communities, and it's a topic that was requested by the attendees of a couple of these sessions last summer. So we're going to discuss anemia in remote and Indigenous communities today. And I'm going to focus specifically on a lot of the socioeconomic factors and how they contribute to this topic, because that's really something that is of particular importance. Just to get the official stuff out of the way, my name is Ben Thomson. I'm an associate professor at Queen's. My clinical work is mostly in the Toronto area. I currently serve on a couple panels with the provincial dialysis groups. I've received some speaker fees from Baxter in the past, and I have previously had research grants that I no longer have, and no mitigation is required because none of the content of this talk relates to any of this previous work. So the learning objectives today, we need first to understand the epidemiology of anemia in Canadian Indigenous communities. And this is important because it's very, very different from the general population. We need to understand how socioeconomic factors modify these patterns in these communities. We'll go over very briefly the differential diagnosis of anemia. Now, that's not going to be the main part of this talk, but we'll discuss it very briefly because it does need to be modified slightly based on the resources available in the communities. We're going to go in a little bit more detail about two very common causes of anemia that you'll see, iron deficiency and B12 deficiency, when to refer to a specialist, and then finally, we'll go over some cases specifically to identify some management plans. So before we even talk about any of this, I'm going to introduce a case as it illustrates many of the unique factors in your communities. It's Judy Shashish. She's from Attawapiskat. She's 58 years old. She came to the nursing station because of 3 months of shortness of breath. Her past history is really unexciting. She's had some mild hypertension in the past. She takes amlodipine for this. She had a hysterectomy at age 41, almost 20 years ago for menorrhagia, and a cholecystectomy in her late 30s. Now, interestingly, she is married. She has 5 kids. She lives with her husband, 4 of her children, 3 of her grandchildren, and a mother-in-law, all in the same house in Attawapiskat. She's never smoked. She consumes minimal alcohol. She previously worked in the diamond mine in Attawapiskat, but now has moved on from that and works in the band office as an administrator. In light of this shortness of breath, some basic investigations are completed, which identify a hemoglobin of 80, which is low. She's treated with oral iron for 3 months. You believe she is adherent to the therapy, but after 3 months, her oral iron level, her hemoglobin level is 76, so has not improved despite 3 months of oral iron. So the 2 questions on the bottom, we're not going to go into them right away, but how should the diagnostic workup have been done in this case? What would those results have shown? And how might her social history be relevant in this particular case for anemia? So I just want you to think about those 2 questions, and we'll be able to answer those as we go on a little bit more into discussing this. So first of all, the epidemiology of anemia. So anemia is a huge public health problem in Indigenous communities. When we describe anemia, typically we state the normal parameters in Canada are based on sex, age, and pregnancy status. This is important because in some Indigenous communities outside of Canada, there are different normal parameters for hemoglobin in Indigenous communities than non-Indigenous communities. Some of this is based on different altitudes that these communities live in. Altitude isn't really a factor in most Canadian Indigenous communities, but there are some people who would argue that the parameters of hemoglobin should be different in Indigenous communities. That's pretty controversial. The lack of race as part of the normal hemoglobin parameters is an important subject of discussion and beyond the scope of this talk, but there is some evidence that the normal hemoglobin does differ based on race, when North American Black people typically have a lower hemoglobin than white North Americans. However, this difference is probably more easily explained by differences in socioeconomic factors. And many of those factors are actually also really important in Indigenous communities in Canada. So we know that the prevalence of anemia is particularly high in these communities, ranging in some studies from 30 to 60%. Infant anemia is particularly disturbing and can be found in more than half of Indigenous infants and children in some communities. Now, why are these rates so high? Well, there's likely a few reasons. So there is a fair bit of Canadian data on this, actually. There are many contributing factors. So the use of cow's milk or evaporated milk rather than iron-enriched infant formula is likely a significant factor. The lack of food security is also very important, as vitamin-enriched fruits and vegetables are often replaced with foods that are less enriched, such as processed foods. The low quality water and sanitation contributes to significantly higher rates of intestinal infections that leads to malabsorption or malnutrition. Higher rates of Helicobacter pylori have also been confirmed in Canadian Indigenous communities, which means higher rates of gastritis and ulcers of the upper gastrointestinal tract. Some communities also suffer from higher rates of early pregnancy and higher teenage pregnancy rates, and this is known to be a risk factor for iron deficiency anemia in adult women. And there are a number of anemia causes that have been described specifically in Indigenous communities. I'm going to describe a couple of those in cases today, but they're most often related, at least in part, to socioeconomic factors. Now, I won't list them here, as I will discuss them later in the talk, but I don't want to gloss over that comment. You know, we often say this may be impacted by socioeconomic factors, but that's not enough to say it. You know, these photographs on the left, these are from Cat Lake First Nation Reserve. And a state of emergency was called in 2019 due to poor housing conditions. And you can see examples of that, with more than half of the homes having high levels of mold that can cause significant respiratory illnesses. Many of the houses are in such bad condition that the only option for them is to be demolished and rebuilt. So inevitably what happens in these communities is there's significant overcrowding in the houses which are suitable to live in. This is an example of that. On the right-hand side, this is Niskanga First Nation, also in Ontario. There's been a water boil advisory in this community for over 25 years. There's still dozens of Indigenous communities with water boil advisories. So what happens when there isn't access to clean water? Well, it means that people are at exceptionally high risk of diarrheal illnesses, chronic bacterial or intestinal parasitic infections. That leads to malnutrition. It also means people try to live in those houses that are safe to live in. And you can see that in the bottom right corner here. Houses intended for maybe 3 or 4 people have dozens of people living under the same roof. And this happens in many of our communities, further increasing the risk of illnesses being shared. The lack of sanitation and clean water means the ability to clean clothes, towels, bedding is reduced. This increases the risk to bed bugs and other pests. This is a map as of January 22nd of this year of all the boil water advisories in Ontario. At that time, there were 72 communities in Ontario that had boil water advisories, and over half of them were in Indigenous communities. Now, before you think this is just related to the recent weather or some acute change, it really isn't. You know, about half of those in Indigenous communities, half of those water boil advisories in Indigenous communities have lasted over 2 years long, and 8 of them for more than a decade. So of all the boil water advisories in Ontario that have been over a decade long, all but 1 of them are in Indigenous communities. And the majority of Ontario boil water advisories that have lasted 2 years or more are also in Indigenous communities. And those that are in non-Indigenous communities are predominantly in small farming areas in Ontario that impact very small non-Indigenous populations, whereas those boil water advisories in Indigenous communities are in the entire community. Now, why is this important for anemia? Well, let's think about what people do or what they're told to do in a boil water advisory. So this is the Center for Disease Control, or the CDC in the United States, advice on what to do. in a boil water advisory. So first of all, hand washing, use tap water and soap, scrub hands in soap and water for 20 seconds. For bathing and showering, important not to actually bathe babies and young children in that water, to instead sponge bath. Don't swallow any water when bathing or showering. Brushing your teeth with boiled water or bottled water. And then washing dishes. There's a long explanation about how to go about doing that in a safe way. And then even something as simple as children playing with toys. Those toys have to be washed in a specific way with bottled water, boiled water, or water with bleach. So you can imagine, even if you were to be successful in being strictly adherent to these recommendations, it's very difficult to be adherent with these recommendations. And there's, in all these communities, higher rates of diarrheal illnesses. And so what happens if you can't be perfectly compliant with these recommendations? Well, we'll talk about what types of anemia specifically we might see with this, but it leads to multiple different viruses, bacterial infections, chronic diarrhea. That typically leads to malabsorption, decreased oral intake, malnutrition, and all of that environment increases the risk for different types of anemia, most prominently iron deficiency anemia, but the other types of nutritional deficiencies as well can be seen in these circumstances, including B12 deficiency. So keeping all this in mind, let's talk about the diagnosis and workup of anemia, of a case that you see at the nursing station, like Judy Shishish in the first case. So there's two general approaches to work up anemia. And the first uses reticulocyte count. Now, I'm aware that this is not a test that's available in your communities. I'm going to go over it just so we can understand the logistics of this and how it is potentially relevant to understand it and what you can use to replace it that uses a similar logistics. So typically what happens when hematocrit is the percentage of blood volume made up of red blood cells. When this value is low, the bone marrow should release more early red blood cell precursors into the peripheral blood. Those are called reticulocytes. When there's sufficient precursors or growth factors to make red blood cell precursors called reticulocytes, there'll be an increased number of those cells in the peripheral blood. But when there's insufficient amounts of those precursors like iron, B12, folate, or another product needed to make those cells, then the reticulocyte number is relatively low. We can use a calculation called the RPI, or reticulocyte index, to calculate that, but the reticulocyte count isn't available in most of the communities, not practically. So what do we do instead? So there's a couple things that I want you to take away from the reticulocyte count. It's that reticulocytes are large cells, much larger than mature red blood cells. So if you were able to figure out a way to calculate how many cells are large and how many cells are a different size or smaller, that would be very helpful. And we can do that without a reticulocyte count. And so what we do instead is we use what's called an RDW. And so because reticulocytes are large cells, when there's two populations of cells of very different size, the red blood cell distribution width, which is a measure of the variance in the size of red blood cells, that goes up. And that's a very helpful measure. So when you see the RDW, which is reported on your complete blood counts, when that is raised, there's really three possibilities. One of them is that you have a high number of reticulocytes. That's one possibility. The second possibility is you have a mixed deficiency, meaning you have small cells, like in iron deficiency, and large cells, like in B12 deficiency. Alternatively, you could have small cells, like in iron deficiency, and some chronic disease that causes large cells, like pregnancy, thyroid, or liver disease. And so that's a way that you can get around not having access to the reticulocyte count. So this is the second approach, and this approach is actually the one that you can rely on in your communities, because all the information that is available to use this approach is actually available with the local labs. And so we're going to go over this a little bit. So when you establish someone is anemic, on the report for the blood count is also reported a mean cell volume. That's basically the size, the average size of the red blood cells. When this is less than 80, it's considered microcytic, 80 to 96, normocytic, and greater than 96, macrocytic or large cells. And with those, you can actually clearly put people into categories that you can have a nice list of things that it might potentially be. And for reasons that go beyond this talk, there's a simple list of reasons a cause can be in each of these categories. I'm not going to go through each of these. I can provide you with the list, and that will be simple for diagnostic purposes. And I don't want to go over an extensive diagnostic bit here today. The key thing is to understand specific risks in your communities. So by far, if you have someone with microcytic anemia, by far the most common cause of that is going to be iron deficiency, then anemia of chronic disease. But there's another cause which is of particular importance in Indigenous communities and has been described predominantly in Indigenous communities in Canada, and it's lead poisoning. Typically, this has to do with a number of sources of lead exposure. So older lead paints, if they're ingested, batteries, if they're ingested, that's typically the most common cause outside Indigenous communities, but there's a very important third exposure, and I've shown this in the X-ray here. This is an X-ray of a young girl in Saskatchewan whose parents had gone hunting, and they'd gone hunting with shotgun shells, with either birdshot or buckshot, which is essentially lead pellets. And when the lead pellets get into the game meat, they're subsequently ingested, and then they end up being in the gastrointestinal tract of those people who are eating the game meat. And so this is not an uncommon X-ray in Indigenous patients who are eating game meat that was killed with birdshot or buckshot. And that is one mechanism with which people can get lead poisoning, and it's been predominantly described in Indigenous communities. There are two other causes here, thalassemias and sideroblastic anemia. I'm not going to go through those because they're exceptionally uncommon in Indigenous communities. You will see that in Mediterranean people or from the Middle East, but not something that you're going to see in your communities terribly often. Those are predominantly congenital disorders, and you won't see those very often in your communities. When you think about normocytic, that's in the middle here, and normocytic, there is some overlap, as you can see, with microcytic anemia, specifically with early iron deficiency and anemia of chronic disease. You'll also see combined deficiencies. So patients who have chronic malabsorption to iron and B12 can actually present normocytic because they have a mixture of microcytosis from iron deficiency and macrocytosis from B12 deficiency. And so hemolysis and bleeding can present with either normo or macrocytic, and you'll see there's some overlap there as well. And then I've provided the list there of macrocytosis with anemia. And I'm not going to labor on about the diagnostic process here, other than to provide you with a list that you can easily check with your cases. And even if you wanted to have this at the nursing station printed, that would be an easy resource for you. But I really want to focus instead on the specific risks in your communities. So how do you tell these apart? Well, there are a few diagnostic tools I'm going to go through quickly because it does get us nicely into talking about iron deficiency. So iron typically binds to a protein called transferrin in the blood. When the iron levels are low, the liver tries to compensate by producing more of this protein. But what it means is that you have a lower percentage of your transferrin bound to iron. And so that represents your transferrin saturation. So that would be low in iron deficiency. But your transferrin saturation reflects the amount of transferrin bound to iron. When there's chronic inflammation, on the other hand, ferritin goes up because it's an acute phase reactant. It'll go up if you're hypoxic, have an infection, cancer, inflammation. So one way to tell iron deficiency anemia from anemia of chronic disease is the ferritin, typically low in iron deficiency and normal or high in anemia of chronic disease. Similarly, you'll notice that the TIBC, which is the amount of transferrin, regardless of whether bound or unbound, that'll be higher in iron deficiency anemia because the liver is trying to produce more transferrin, but it'll actually be low because it's suppressed in anemia of chronic disease. I have put sideroblastic anemia there only because you'll notice that the parameters for iron are all completely different. Now, I put here as well, you'll often see the lab will suggest to you, this looks like iron deficiency based on the low ferritin, the low iron level, the low transferrin saturation. But specifically in Indigenous communities, it's worthwhile asking about the exposure to lead paints or game meat, because you might also be thinking about lead poisoning. And even though that's rare, the populations we do see lead poisoning in are often Indigenous. So I have provided a list here. I don't want to go through this in great detail, but every patient with anemia, we need to take a full history of their dietary habits, their bowel habits, ask if there's any occult bleeding, past medical surgical history, what medications they're on that might increase the risk of bleeding. And all women of childbearing age should have a pregnancy test. Now, I have listed the tests that can be done here for anemia. I'm not going to go through these except to say that you can print off this list and have it available to you for different cases of anemia. Typically, we order a blood smear. That's not available in most communities, and reticulocyte count is not available as well. But the other tests here in numbers 3, 4, and 5, most of these are available, and you could do these reasonably well in most of your communities to identify the cause. All right, let's go back to our case. So back to our case, we're going to go back to Judy. Remember, she's 58. She's had 3 months of progressive shortness of breath. She's married with 5 kids, and she lives in a house with 4 kids, 3 grandkids, her mother and her husband. And she doesn't drink alcohol. And remember, her anemia did not respond to 3 months of oral iron. You believe she was compliant to the oral iron prescription. So if you had a chance to go back on your first visit, what would you do in addition to just ordering the blood count? Well, you'd want to know the mean cell volume. That would be helpful. And in this case, it's 97. You'd also want to ask, is she of childbearing age? Well, she's 58 and she's had a past hysterectomy, so you don't need to do a pregnancy test in this case. And then based on that mean cell volume of 97, these are the additional tests that I've just basically copied and pasted directly from the previous slide that gives us all the tests that we could do in this situation. So these are the important results. And so in addition to the blood tests, you will notice that you did a physical exam, and you notice that she has a lot of skin lesions on her legs and on her back that look almost like bites. And she's had these even prior to the initial presentation of shortness of breath. And then when you look at her blood tests, you'll notice that she has, her MCV is at the higher end of the normal range. Her iron stores are low, but she's got iron deficiency anemia by the iron stores, but interestingly, her mean cell volume is on the higher end of normal, which is a little bit odd. And that might suggest, perhaps, that she's producing a lot of reticulocytes, which are large cells. So again, one of these situations where you have a mixed proportion of small cells from the iron deficiency and large cells from the reticulocytosis. And keep in mind, she lives with her husband, 4 of her kids, 3 grandkids, mom in a house. So what's happening? I'll tell you what happened. So her social history is very, very relevant, because what happened, these bites are actually bed bug bites. And these had been going on for months in her house, in large part because of the congestion of having so many people in the house, having a water boil advisory, and being unable to consistently clean the bed sheets. And so as a result, in fact, everyone in the house was impacted by a bed bug infestation, unfortunately. And clean bedding was simply not an option, unfortunately. So I'm going to move on from here. So you can see the cause here was bed bug anemia. This is actually, these pictures are taken from a case published in the Canadian Medical Association journal from an Indigenous community in Ontario. So this is a case of a community that had a water boil advisory, leading to overpopulation and subsequently living conditions that were quite congested, and several houses were unfit to live in. Let's talk about the second case. This is a 37-year-old man. His name is John Peters. He lives in Red Lake. He comes to the nursing station with several weeks of numbness, tingling in his fingers, and decreased energy. He is known to have schizophrenia as well as depression, and was actually admitted to the psychiatry ward in Thunder Bay in 2018 after an episode with psychosis. He was discharged at that time on olanzapine, and he was unfortunately lost to follow-up after he returned to the community. He does have a remote history of chronic alcoholism, but he hasn't had any alcohol since his discharge from hospital in 2018. He lives alone in his brother's shed, part of his brother's property. And while he does have 3 siblings and his mom is still alive, he doesn't have much contact with them. He currently is not working. He doesn't drink alcohol, but he does smoke a pack of cigarettes a day. So you organize some investigations for him, and you identify his thyroid, liver function. Everything is normal from those investigations, with the exception of his hemoglobin, which is 75. His mean cell volume is normal, so it's 95, so it's within the normocytic range, but he hasn't had any blood work since his time in hospital in Thunder Bay in 2018, and at that time, his hemoglobin was normal at 129. He's in clinic. His vital signs are normal. You do notice he has cracks at the side of his mouth. His fingernails look like big spoons, which is something that's often described in iron deficiency anemia. The term is koilonychia, but it basically means just over chronic period of time with iron deficiency, the fingernails almost look like upside down spoons. He is behaving oddly, and he is having probably visual and auditory hallucinations during your physical exam. So I'm going to stop here. And certainly he has normocytic anemia. Based on that, there's a number of organizations from the previous slide that you're going to order. But a couple things I want to ask. So what would you like to order? But also, how do you think his socioeconomic situation might be somehow contributing to his anemia? I'd like you to think about this, and we're going to go through this a little bit. So here are the results of his further investigations. So you do his mean cell volume, it's normal. His iron stores are low, so he fulfills criteria for iron deficiency anemia. His B12 is also low. Thyroid's normal, folate's normal, liver tests are normal. The tests we do to look for hemolysis are normal. So he is, his iron studies are consistent with iron deficiency. This would produce low or low normal mean cell volume. But here you see the mean cell volume is actually normal. So that might suggest a mixed deficiency here. And that is in fact what's happening, because he has B12 deficiency as well. Now, B12 deficiency on its own requires a workup. Usually an internal medicine or hematology person would do that. It usually often can be because of B12 malabsorption. And there's a lot of reasons why someone in an Indigenous community might have B12 malabsorption, whether that is related to previous surgery to remove part of the stomach, chronic Helicobacter pylori infection, chronic alcoholism. Any of these have an increased risk of B12 deficiency. So what we did in this case is we contacted Mr. Peters' family. He hadn't been in contact with them for a while, but they were able to examine his living space. it was found to be in squalor. He had hundreds of instant noodle packages and empty Tang drink mix packages. He'd been living basically on instant noodles and Tang juice for months and possibly years. Neither of these contained significant amounts of iron or B12, and as such, he had developed a mixed deficiency. Why was he eating only instant noodles and Tang? Well, his uncontrolled schizophrenia probably is a factor, but there's another important factor. This is a 2-minute video. I'm going to play the 2-minute video, but for those who are calling in by phone, the video is available at the website link, and it's highly relevant to understand the food insecurity and how this impacts these communities. So I'm just going to play this video for a couple minutes here.
Oh, we don't have any sound.
Oh, okay.
So I think if you just go back to sharing your screen, I think there's actually a button, like a little checkbox. If you want to, if you just close the screen share and then you reopen it, there's a checkbox.
Okay.
So if you, if you try to,
so share screen and then.
Yeah, there should be a checkbox in there.
Oh, share sound. Perfect. Yeah. Got it. Yeah. Yeah. Perfect. Okay. Thank you. Okay, I hope this works. Please let me know. Does that work? Is that working?
Yes.
Okay, perfect. Okay.
Fresh produce like vegetables and fruit will definitely have a difference, not just in price, but in the freshness. A lot of things are frozen, thawed, frozen again, and then thawed again when they are put on the shelf. It affects, I would say, more than half of the people who live in Nunavut, not just Inuit or Indigenous people, but the entire population, because you don't have enough money for rent or to eat properly. Nutrition North Works is federal government approved funding for the North to help offset the cost of transportation for essential items. They allocate this money and spread it out for stores. No one's overseeing how much they're actually passing on the savings and how much they're keeping themselves. So it's really entirely up to the company how they're going to distribute that into what item and how much. It is one of those roles it plays in like having a high suicide rate here, because if you don't have something as basic as proper food, there is no way for you to be completely able to thrive and succeed in other parts of your life. If you have to worry about where your next meal is going to come from.
Okay, so that I'm going to move on. Oh, I'm sorry. That's going to move on. to go over specifically about iron deficiency anemia, because this is the most common type of anemia that you're going to see. If you have someone with iron deficiency anemia, they do need replacement, and we're going to talk about the options we have for that. But there's a lot more you need to think about here. If he or she is over the age of 50 or has a family history of gastrointestinal disease, they should probably be referred to have an endoscopy with gastroenterology. You should ask women about gynecological bleeding and refer to gynecology if appropriate. Now, typically what we do is we prescribe oral iron for 1 to 2 months, and we assess the response. And I understand the nurses and nurse practitioners are able to prescribe certain formulations of iron, and we'll go over those. Usually we do about 1 to 2 months. We assess the response, and then if there is insufficient response, we have a number of options. Usually intravenous iron can be considered, or the other alternative is to go back and ask these questions, because really it might suggest that there's some chronic blood loss. Iron deficiency is the most common that you're going to see, and is more common in Indigenous communities, with rates over 50% in some communities. So what's important to think about here? So which oral formulations are available? When should I consider using intravenous iron? What are the advantages of intravenous versus oral? Are there alternatives? Which is best in pregnancy? And which medications do I need to worry about with oral iron to avoid taking at the same time? So there's 3 most common options for oral iron are ferrous fumarate, gluconate, and sulfate. Now you'll see that any of these can be prescribed from once a day to 3 times a day, but it is established that increasing the frequency markedly increases the likelihood of side effects and may not have much of an impact on improving the hemoglobin level beyond once a day. Some advice giving vitamin C. Typically, giving vitamin C simultaneous to oral iron increases the amount of ferrous rather than ferric form, and so that increases the absorption of iron. While this theoretically makes sense, there has actually been oddly very little evidence to support this practice of giving vitamin C. Now, we expect about 1 in 3 patients to complain about side effects with oral iron, and this is worse with increased frequency dosing, maybe worse with ferrous fumarate than other formulations. Not surprising that fumarate is the worst because it contains the highest amount of elemental iron, and so you have the worst off side effects. Now, oral iron, there is a limit to absorption. Gastrointestinal side effects, very common. Many people who have malabsorption conditions like inflammatory bowel disease, celiac disease, or end-stage kidney disease actually leads to malabsorption. So there's also multiple drug interactions with oral iron that we're going to go through that are not with intravenous iron. Now, there are some advantages of oral versus intravenous. It's certainly cheap. IV iron requires you to come to a healthcare facility which is expensive, and you know, because it's only administrable in that in that setting, it means someone has to go to that location to get it, as opposed to just taking it at home. So here are the forms, the most common forms of iron supplementation. You'll notice, thank you, Marika, for letting me know about this, the iron fish. So the solid iron fish on the left is actually literally an iron fish. It looks like a fish, and it's made out of iron. It has recently been recommended by the World Health Organization to supplement iron. And what the patient does is they simply add the fish directly into boiling water, and it adds about 6 to 8 milligrams of iron per liter of boiling water, which gets integrated into the food and has the advantage of significantly lower rates of gastrointestinal symptoms with it, with obviously the caveat that the amount of elemental iron is a little bit less than if you were to take medications for it. Now, you'll notice of the oral iron, the fumarate followed by the sulfate, followed by the gluconate, has the most elemental iron. So to no surprise, the fumarate does have the most side effects of all the oral formulations. Typically, the daily requirement for children is about 15 milligrams a day, depending on the age. This goes up to about 20 milligrams in a man, 18 in a female. but pregnancy, the state of pregnancy has the highest demand, and typically about 27 to 30 milligrams of iron per day. And those patients who are iron deficient, of course, will require more than this to compensate for the deficiency. So this is to go over, it's important to consider other medications a patient might be on when giving oral iron. Keep in mind that if you're on an acid lowering tablet, like a proton pump inhibitor or a histamine blocker, less of the ingested oral iron is going to be absorbed. So these patients may require a higher dose than those not on these drugs. Similarly, they should space apart certain medications like thyroid tablets, certain antibiotics, oral calcium supplements like Tums, coffee, black tea, Cinemet for Parkinson's disease, several cardiac medications, some immunosuppressants, and a couple seizure medications, including oxazepam and Dilantin. So you can see the list there is pretty extensive, and you know, for many patients who are on, even 5 or 6 medications, it just taking oral iron becomes impossible given the other medications, the side effects, and everything else. Now, in pregnancy, you should recall the recommended daily intake is about 27 to 30 milligrams a day. Diet is insufficient for most pregnant women, and so an oral iron supplement should be taken by pregnant women. Now, some pregnant women simply can't tolerate oral iron, and in some of these women, it may be possible to do every other day dosing. This appears to have similar maternal and fetal outcomes with reduced side effects, but more of these mothers will suffer from anemia at birth, which will potentially mean the breast milk is less iron rich and thus also has the potential to precipitate iron deficiency in the newborn. 2 oral formulations are alleged to be better as far as side effects in pregnancy. I'm going to tell you the evidence for this is really bad. It's not very good evidence, but these 2 formulations are at least advertised as superior in pregnancy. Ferrous bisglycinate, or the other name is Ferrochel, is one option, and Maltofer, otherwise known as ferric iron polymaltose, is an alternative option. Maltofer does have the advantage of having higher amounts of elemental iron, but the honest truth is there's probably not much difference in side effects. If there is, it's very small. I'm going to touch very briefly about B12 deficiency because you will see it in your communities. Typically, we find B12 in animal origin products like beef, chicken, milk, eggs. Most cereals are now fortified with B12. And there's really 2 groups of people at risk for B12 deficiency. The first typically have pathology of the gastrointestinal tract that leads to decreased absorption. People with severe gastritis from Helicobacter pylori, chronic alcoholism, so people who've had surgery on the stomach that removes part of the stomach required for absorption. And there's also patients who have decreased intake in their diet. Classically, vegan patients or infants of vegans are at risk, but also chronic alcoholism is at risk, and people with underlying psychiatric conditions that are poorly controlled. Now, I'm not going to discuss symptoms or management of B12 because that is somewhat a subspecialty within itself, only to say that if this is confirmed, these patients should be referred to either internal medicine or hematology for replacement, as this is not as simple, is not as simple as giving B12. It does require a little bit of a workup, but this is something that you should at least be thinking about in your patients. This is the last case. It's pretty quick. Paul Nakaji comes to your nursing station. He's 69. He's got 6 months of progressively decreasing energy levels, reduced appetite. He has an extensive past history. He's diabetes, hypertension, dyslipidemia, coronary artery disease. He previously drank excessively and does have alcohol-related liver disease, but hasn't had a drink for over a year since his wife threatened to leave him if he didn't stop drinking. His medications are listed here and are expected as per his comorbidities. He's retired. He's worked in the mine for years and then took a desk job in the band office before retiring at age 65. He lives with his wife in a home, and his children are all grown up and living outside the community. You do some blood work. and the results are shown. So all of his blood work is normal except for two things. His hemoglobin is 78, normocytic, and his creatinine is 185, which is high. And you do have previous kidney testing from a year ago, which was normal. All the other blood tests are normal. And the point of this here is that if you have someone who has new diagnosis of anemia and kidney disease at the same time, this is someone who needs a referral for consideration of multiple myeloma, because typically those two systems are affected first. If there were also hypercalcemia or bone lesions, that would also increase the probability that this could be multiple myeloma. So these types of patients should be referred to hematology and nephrology consultation, or at the very least, internal medicine. Okay, so that's actually just summarizing the case that I just went over. So, so I think, you know, when we think about anemia in an urban setting, it's very, very different from what you are going to see. And more than any other community, you know, really, I think we have to consider the patient more than just the anemic patient with a diseased organ, more ever than the whole man. We must view this patient in his or her world, where we understand the circumstances that they're in, which are going to increase the exposure to risk factors for anemia. So thank you for your time. I'd be happy to go through any questions with you. I'm going to try. Oh, there we go. Yeah. So I'm happy to answer any questions you might have.
Hi there, it's Veronica here. I'm one of the nurse practitioners. I just wanted to ask if you suspect lead plays a role, is that something we should be testing for?
Yeah, if you suspect, then yeah, you should test for it. It is treatable. So there are chelating agents that can be prescribed that lower the zinc levels, and it is associated with a lot of significant morbidity, especially in kids, where it's associated with increased risk of behavioral disorders, neurological development. So it is something that if you suspect, probably you should be doing just a serum lead level. And that's all you need to do. It's a simple test. You know, it's not something that you'll see often, but the groups of people that you should be thinking about are the ones who are eating game meat that might have some shotgun pellets in it. And outside Indigenous communities, eating batteries and, you know, ingestion of paints is considered the risk. And that's not, you know, really something that we see in Indigenous communities. The most common precipitant there is eating game meat with shotgun pellets.
Thank you. And the other question I have is the H. pylori. I guess, should we be checking that more frequently as well? Because we do get lots of people complaining of, you know, stomach upset. And a lot of people, especially women, come in with like hemoglobins around or below 100. So should we be checking that more regularly as well?
So it's not a bad idea. You know, if you saw an anemic person with dyspepsia or, you know, upper gastrointestinal tract symptoms, probably what I would be doing, I would initially prescribe them a proton pump inhibitor to see if their symptoms improve. Testing for Helicobacter pylori in those circumstances is very reasonable, given the disproportionate high rates in Indigenous communities. The nice thing about Helicobacter pylori is it's treatable. And chronic Helicobacter pylori associates with not only ulcers, but also gastric cancer. So it is something you want to identify and you want to treat if it's there.
Thank you.
I see a question from Colleen. So Colleen is asking if you could tell us the difference between the 3 iron supplements, the difference between sulfate, fumarate, and gluconate. Does it matter which one the patients receive? The iron in stock at nurses' stations changes from time to time. Yeah, good question. So, you theoretically, the fumarate contains more elemental iron, and so theoretically it should be better as far as resolving iron deficiency anemia, but it associates with increased side effects. Probably, it's about 30% of most patients on oral iron, but with the fumarate version, it's probably about 40% get gastrointestinal symptoms. So it's really, there isn't a perfect oral iron option. Unfortunately, you end up using what you have. And oftentimes what I do is I'll start on ferrous fumarate. If the patient can't tolerate that, I'll switch it to sulfate or gluconate. And if they can't tolerate that, I'll organize intravenous iron. But unfortunately, these decisions are often made for reasons other than patient tolerance.
Hi, it's Ha. If I may add, the formulary iron supplement that we carry is iron gluconate for the adults and iron sulfate for the pediatrics because it's the liquid form. If you have other types of oral iron in the formulary, that might have been a mistake in the ordering. Thanks.
Okay, that's good to know. So the fumarate version isn't available from the sound of it on the formulary.
No, it isn't, because we figure it would be a little bit less tolerant than the other iron salts.
That's absolutely true. And the ones that I mentioned for pregnancy, the Maltofer and the bisglycinate, are those ones available, or do we simply use the alternative ones you already mentioned?
Yeah, we do not have that, but I'll have to dig a little more into it. And I have to look into Proferin as the other option.
Right.
Of course, that's a lot more tolerable and better absorbed. So I have to dig a little bit more on that.
Right. I'm seeing a Galaxy A9 Pro question. Iron sulfate seems to cause more constipation. Would high doses of vitamin C mitigate the constipation? Answer to that probably is no. So, vitamin C, it's interesting because it's one of these interventions that has a theoretical benefit that just has not panned out anytime it's studied. It's something that hematologists will recommend and internal medicine docs will recommend, but when it's been studied rigorously, it really hasn't. When you look at 3-month hemoglobin and iron stores in people with or without vitamin C, they're not different. So it makes theoretical sense that it should work, but the studies just haven't confirmed it. As far as constipation, again, there's not really much evidence that giving vitamin C alleviates symptoms of oral iron prescription either. So it's not something that we would usually prescribe it for. Were there any other concerns? Oh, adding magnesium may help. Yeah. So the comment was maybe adding oral magnesium would help the constipation associated with taking oral iron supplements. And that's potentially true, but magnesium is also associated with gastrointestinal side effects of its own, including abdominal discomfort, cramping, increased gas, and many of those do overlap with iron supplementation. So it might, while it might counteract the constipation, it might give you some other issues as well that might be difficult to differentiate from the oral iron supplementation.
Okay, if there are no more questions, then thank you so much. This was helpful. Will there be an evaluation link, or?
I can, right, I don't have the evaluation link. Let me, can I email that to you in a few minutes?
Yep,
Okay.
We will send that out.
Okay. Perfect. And we will be having sessions as per your input topics as per the input provided in the evaluation. So important you complete them so that we can make sure the topics remain relevant for you. Okay. Okay. Thanks very much.
Just before everyone leaves, I just want to, if you can comment, we're trying our best to make sure that there is content that is for everybody. So if you can put that evaluation on whether you feel what you took from it, the level you felt it was at, further sessions you would like, all of that is important to us. Okay, and thank you, and we will hopefully see everyone next week.
Thanks very much, guys. Have a good day.
Thank you.
Bye. Thank you.
Thank you.